We've been talking a lot about innovation, and now we want to talk about how FHIR helps to foster that innovation. In some ways, the very high-level overview I'm about to give you would have come a little better just before Dimitri shared all that cool stuff underneath, but that's okay. So if you're not comfortable with FHIR yet, we're going to go back 150 years and think about the telephone. So back when the telephone was first introduced, it revolutionized communications. It was great. You could suddenly talk to somebody who wasn't right there with you. But it required a huge investment in infrastructure. And it was an investment that wasn't necessarily possible if you weren't in an urban area or you didn't have a wealthy region. It also required an incredibly high-touch set of human interventions and physical connections for each point of contact you wanted to make. So it was wonderful, but it was kind of heavy to implement. Let's move ahead to just a few years ago with the introduction of mobile phone technology. Mobile phone technology doesn't require the same kind of heavy-duty infrastructure where we've got to cable everything together. And so it was much more widely adopted, much more rapidly. Because it was widely adopted and because smartphones have become so prevalent, in fact, we think there are going to be about 6.8 billion smartphones around the world in 2023. That fostered a whole ecosystem of innovation that uses the smartphone. And it changed the access to healthcare services in some parts of the world. In rural communities where there wasn't the specialty care, the smartphone now becomes an opportunity to give that care. In fact, there's an estimate that there are about 350,000 digital mobile health and wellness apps between the combined Android and Apple marketplaces. 350,000. That's ridiculous. How do you choose them? So this was a great opportunity to innovate. Well, what does this have to do with FHIR? Because FHIR is dealing in health records. Well, we went through a similar kind of process with health records. If you think about it, the original handwritten records that were used in doctors' offices or hospitals, they didn't have a whole lot of utility. They served as a mnemonic, a reminder to the clinician about what this patient that they're just looking at has done in the past. But you couldn't really use it for analytics. You couldn't use it to understand the epidemiology of a disease. As we moved toward hospital-based care and health information management professionals, we got much more sophisticated about medical records, and we could do more with them and do more comparisons and use them to foster studies. But health IT really made the difference in starting to make that data accessible to us. And all of a sudden, we could start to move data around more easily. We could look across records. We could begin to do analytics. We could generate performance measures and look at how to normalize care more and manage cost and quality and utilization. The trouble is that just as we had all those phone lines stretched across the cities, when we moved to health IT in the early days, we had to have all these point-to-point interfaces to try to integrate everything. And usually that integration snarl was happening just within the organization. It didn't help going across organizations and across facilities. Furthermore, it required an army of engineers to build out each interface individually. And it could take months and months to deploy a new interface because the way it was understood by this data was understood by the sending system and data was understood by the receiving system were totally different. So that's when we saw organizations like HL7 get going and collaborations across the industry to help us say, in this field, this means X. And the receiving system could say, yes, I understand, that is X. And that was great. HL7 began to help us normalize. Furthermore, we put in architectural models like hub and spoke integration that made it much easier. We weren't having to do all these point-to-point integrations. But the early standards were document-based and were heavy. So when you think about a referral, the GP says you need to see a specialist, let's send the record. HL7 will send that as a CCD document, which can be 100 pages long. Dimitri was talking about how irritating it is when you go to the doctor and they ask you all the questions you just got asked. We've already sent that CCD. Why do you have to ask me all over again? Well, I'm going to order that test because I can't sort through all this crap. It's too much. I don't have time. I don't want to deal with it. We needed a granular approach, and that's where FHIR comes in. Because FHIR helps healthcare and health information act the way the rest of our economy acts. So think about it. When I was planning my trip here to Bangkok, I live in Washington, D.C., I didn't want to talk to my travel agent until I understood what the options were and who flew here and could I get a nonstop and what was going to be involved in this trip. So I went to Google Flights and I said, I want to come on these dates and what's out there. Well, Google doesn't store a catalog of every airline and every flight and what the connection options are. Google does a query, and the airline sites return data using the same kinds of APIs that Dimitri just showed you. And they're returning only the information they need, not information about flights to Beijing and flights to Tehran and flights to London, just the granular information it needs for that query. Similarly, if we wanted to go out to dinner tonight, I can go to OpenTable, and the restaurants in its network can support a query from OpenTable to say, I want a table for 10 in Bangkok tonight. What do you got available? Who's got space? And what time do they have space for me? Well, with FHIR, health information can be served up the same way. So a modern EHR like TrackCare can push out data as FHIR-based APIs. And an organization like CVS Healthcare, which is a major retail pharmacy chain in the US that has clinics in many of its pharmacies. They can build a website for me to use as a consumer. And if I had said before I came to Bangkok, I want to go meet with somebody and find out whether there are vaccinations I need or health concerns I should think about, I can go to their website and say, tell me which of your pharmacies has a travel health clinic, where are they, how far are they from my house, and when do they have appointments? And the CVS app can go query the EHR for each of those sites. They can come back and they can give me that information. So now I'm happier because I've solved my appointment problem on my own quickly. And the next time I want to see a clinic, I'm going to go back to the CVS website and use it again. It's not only allowed me to do a task that's important to me as a business, but that innovation, that approach that FHIR has enabled is building my customer loyalty, which many of us really care about as we're building out our businesses. And by the way, one of the reasons I started with the telephone and with mobile communications is because FHIR is critical to most of those health and wellness apps we talked about. Dimitri mentioned the Android Commons project and Apple Health Kit, and they connect up to devices. And patient monitors can be used now to build out new models of care, like hospital in the home. And that's all based on using FHIR to push just the right information for those applications. So it's tremendously exciting for us as we look at this going forward. Now, have to be Debbie Downer a little bit. FHIR isn't magic. It's not going to instantly change the world. For one thing, there are millions of interfaces out there in place already, and most of them aren't broken. If you've got to allocate staff to a new project, you're not going to fix something that isn't broken. You're going to dedicate time to new projects. So FHIR, for the moment, is going to be seen more in new projects than in old ones. But that's okay. We also have to bear in mind that FHIR is still in its infancy. HL7's been out there for decades. And by the way, FHIR is an HL7 standard, so I'm using a shortcut. But FHIR is a process that is in process of development. So portions of the health record are called normative. They're standard, everybody's voted on them, they've said, yes, we got this right, and all the future versions of the standard will upgrade those particular fields. But there are other parts of the FHIR standard that are not yet normative. They're draft. They're still being worked on, and they're being voted on, and it may be several years before they're final. So we have to keep in mind that it's a continuous process of growth. That's compounded by the fact that we're inventing new kinds of health data all the time. If you think about precision medicine and genomics and some of the new things we're doing, we're creating new kinds of data. And those also have to be rolled into the FHIR standard as we go forward. FHIR is a standard, but just because it's a standard, it doesn't mean that everything can just plug in instantly. You have to understand how the standard applies to a given use case. So in the United States, HL7 runs a cooperative effort called the Da Vinci Project. Da Vinci is a set of vendors like InterSystems, health insurers, and providers. And they're working together to say, if we want to get prior authorization for a service from a health insurer, what data elements are necessary to do that? How are we going to represent them? So there might be a code set issue or a formatting issue. How are we going to represent it in the FHIR standard? How are we going to interpret it on the other end, and what do we respond back with? And that's codified in an implementation guide. An implementation guide that's developed in the US for a particular use case may need to be modified or updated if you're going to use it in Indonesia or in Thailand or in Australia. Doesn't mean you have to rewrite it and start from scratch, so it gets you there a lot faster, but you can't necessarily say it's going to be perfect right out of the gate. So we have to keep that in mind. And finally, if what you want to do is aggregate data from lots of different sources, you have to recognize that those sources may be representing a medication resource in FHIR in one code set, and a different source is using another code set. So there's still a little bit of mapping to do in your aggregated record. And in fact, that's why we have the HealthShare Unified Care Record, because it does that kind of aggregation and normalization and works with you on that. So those caveats aside, we are just incredibly excited about FHIR. We're excited about what people are doing with it. And I'd like to invite Dr. Torikai from Gunma University in Japan to come up now and share the work that he and his team are doing to make care better. Dr. Torikai?
Hi, good morning, ladies and gentlemen. So this is the souvenirs of the Global Summit that held in June in Florida. So I'm a big fan of the InterSystems, and now I'm in social media ambassadors of the InterSystems. Thank you. So today, I want to introduce about the applications of the FHIR technology in Gunma University in Japan. So this is the short summary of the Gunma University. So here is the enlarged map of the Japan. The Maebashi district is in center side of the Japan, and the overview of the hospitals right here. And this is our hospital's homepage, webpage. And the Japanese government is now strongly enforced to produce the digitization or the digital transformation. So as you know, the DX technology. And this is the Japanese documents published by the Japanese government that is the centralized the medical DX. So, and this is the official paper of the Japanese government. So it is to promote the more and more medical DX. And now our standards is decided to the FHIR technology. And the Japanese government policy is promoting the medical DX is the three main categories. One is the creation of the National Medical Information Platform. And the second one is the standardization of the electronic medical records information. And the third one is the medical fee revision digital transformation. And this is the workflows of the project into some categories. This is the medical plans, and this is new infections like the COVID-19. And then this is the regional health, and here is the change of the clinician's workflow. And then here is the medical DX of the outpatients. So the government now planning the big vision to change this is the 2021, and now the 2023. So rapidly the digitization is ongoing. And but our AI's rapid changes our workflow and the changes of the condition of between the laborers and the masters. So that is main Japanese articles, Asahi Shimbun. That is they criticized this is Amazon's company. So they forced to the labor to work more and more with optimizing the workflow and the time schedule. And so the important point is to making the trust between the employees and the masters. So we have to make this technology is to make our communities more happy. So, and the Kathleen many times mentioned about the physicians burns out. That this is the result of the searching result of the PubMed. You know, here is searching keyword is physician burnout, and the middle one is nurse burnout, and the right one is technician burnout. The searching result is so the rapidly emerging. So the burnout is not only the local district's condition or local problem, but it's also the global problem. So so all of us, we know that the hospital is too complex system, and this is the patient line, and this is the staff's line, and they have each time and the orders condition, and here is the many site of the execution site, and so that is the needs of the job, and this is the assignment. So that is the simplified, the visualized system, but in the real situation, the complexities is more and more. So, and one examples of the hospital information system in the Gunma University. The center system is the ordering system or some electronic medical records, and the surrounding system is all of the test So like a CT or MRI or some surgeon system or so. So many the servers and so many devices are working together. So we focused on the one problem that is the traceability of the medication. So here is the incidents, so medical incidents, and here is the 40% of the medical incident is from the medication. And here there's the reported job. So here is the pharmacist, and here is the nurse. So so many troubles happens in medications workflow. And this is the second problem is to the hearing of the patient situation from the from the situation, and that is the result. And the most of the pharmacist complaints is to that difficult to hear the exact situation of the patient. So what is the disease name is, or the how to the intake or some required cares. So we think about to make it digitization. So the one is the hand drawing of the medical system, and here we gather the team and using the technology of the FHIR, so that we make it. So that is the enhanced drug traceability system within inpatients. So here is I introduce about the brief summary of this system. Here is electronic medical records orders, and the ordered medication is checked with RFID. So that is in name of the IC tag. So to check the kind and the patient and the direction of the medications, and stored in another server. And the prescript that the medication is transferred to the inpatient bedroom, and this IC tags that trace where this medication is now lies. And if they start to use it, check the nurse, hear the moving, and our next project is to hear. So the drug traceability is important to when the patient intakes that medication, or check the exact dose of the medication. So here we introduce the medical robots and the AI picture recognition system to check the medication drugs. And here is the system connection. So that is the big PC, and this is the centralized the network core switch. And the FHIR is needed to implement this because it is to enhance the cybersecurity. So we use the help of another server, so that is out of the hospitals. But we required the connection with the other outside of the hospitals. It requires the high cybersecurity performance. So the current technology, the web implementation technology or the FHIR technology, helps to enhance the cybersecurity more rapidly. So that is the simplified show diagrams, and to speed up the connection. So now using the local 5G technology. So I show the brief summary of the demonstration of the drug identification. So here the picture taking that's the patient side, And this is the identified result, and here the manipulations. And here is some recognition result here. So we can identify the many types of the medication drugs in the same time, up to the 10 categories. Okay, and that is done by this machine, but it's not only for stationary, that is moving with this robot. Okay, so I'll do the demonstration here. So the bottom one is the robot just moving automatically to the patient room, and the black box is the drug recognition system. And taking picture is transferred to the AI engine, and the result is returned to here. And at the same time, the recognition result write down the EMR system. So just robot is going away. Right, so the user interface is like this. Now this is some kind example of the patient IDs. And the patient ID is linked to the patient bed, and the nurse just push on the patient ID. Then the robot is automatically detects where to move. Then the robot go away. All right. And after reaching the patient bedside, here is the sample of the engineers. So they demonstrate how to identify what this drug is good to the intake or not. So the close the transparency, and then hit the push button. So automatically the upper and the lower sides the camera is installed, and then taking picture, and the transfers the picture data via the local 5G technology. So this is now starting the inspection. All right. So this is the recognition result. So this is the room of the nursing station, and here after the patient pushing in the drug and the checking button, this slide, this UI outputs the medications the patient want to intake. So the nurse or the physicians or some pharmacist test to check it. So where to intake it or not, or some needs consultation. So that here is the sending the data from the patient bedside, and the nurse doesn't need to move to the patient bedside to check it. And if the needs consult, the nurse to move to the bedside, but it reduces the nurse movement very much. Okay, so and this is like a making movie. So he is engineers, and this AI makes so many samples just after the drinking drugs. Over the 1,500 samples he continuously making data to making the AI's recognition. So this is the identification result, and finally we achieved that the accuracy is over the 0.98. So 98% of the drugs are correctly recognized. And this is another result, so the very good user interface to easy to understand our physicians or clinicians. So that is adapted to the government, the investment, and so we succeeded to this project. And this is a summarized slide. So Kathleen says FHIR is not magic, but it helps a lot because of it makes the standards of the data communication. So that is the foundation class of the servers, and the REST technology is the set of one like of the architecture style. So that is a very difficult concept, but the REST means that the 6 important concepts, and if we understand the REST technology and how to make the FHIR, so we can rapidly growing more usable application in a hospital. So this is the security system. So the Japanese hospitals that tends to attack so many cyber incidents in recent years. So we have to enhance the security, and it helps, or the REST that helps to enhance the cyber technology. So this is the last slide. So thank you very much for your attention.
All right. We'd like to invite Julian Petrescu from InterSystems to come and share how InterSystems is working with hospitals and clinics in Indonesia to help on board with FHIR.
As a case study of FHIR and InterSystems technology support for it, please allow me to talk about how we developed a solution to support fast onboarding to Indonesia's health information exchange, also known as Satu Sehat, using FHIR. And if you walked around the room previously, maybe you have seen this demonstrated in the corner by my colleague Kate. If not, please feel free to do so. It's right there. And here's the story behind it. So, pre-COVID, this is the agenda. So we'll talk about Satu Sehat. What is it and what started it? What was the reason behind it? We'll talk a little bit about healthcare information exchanges and InterSystems involvement with them and the different protocols behind them. How we approached delivering this project. And because that's an important topic on its own, we'll touch upon the security concerns in the context of a health information exchange. And we'll summarize by reviewing some of the benefits that this provides. So benefits brought about by FHIR, as well as the IRIS platform that we use to deliver this solution. So what's the reason behind it? Pre-COVID, the Indonesian government did a study and identified some challenges related to the health tech ecosystem in the country. But this is common in many places around the world. So there were many health applications, patient-facing applications, portals, mobile applications, booking applications, and so on and so forth. They were collecting data. So data was accumulated. But they were not really sharing this data. There was a lack of standards, there was a lack of integration between applications, there was a lack of data standardization, lack of metadata. So even when this information was accessible, it couldn't be easily addressed. There was no way to uniquely find a patient or a provider, for example. And obviously this data was not shared with the health system, the health services in Indonesia. So these were some of the challenges. However, Indonesia has some strengths as well. There's a vibrant startup culture in the country with regional unicorns, Gojek and so on, we're all familiar with. So there's a lot of entrepreneurial talent as well as technical expertise. And the government had existing APIs in place, BPJS, used for health reimbursement, claims and reimbursement. And then COVID happened, And the Indonesian government deployed an application called Peduli Lindungi, similar to applications that have been deployed globally in the region. You may be familiar with Thai Chana in Thailand, Trace Together in Singapore. So an application to trace contacts and keep track of COVID immunization records. And based on this experience with rolling out a nationwide application and the platform to support it behind the scenes, the government decided to expand it and build a more comprehensive health data platform to address some of the challenges in the ecosystem identified on the previous slide, as well as provide data for a potential future crisis. So relabeled Satu Sehat, mandated by the government as a health data exchange platform with the goal of connecting information systems and applications from the entire Indonesian health system, including the digital health ecosystem. And they established specifications, mechanisms for onboarding, for data connectivity, data management, technology, and safety. And they decided that FHIR was going to be the standard used to enable data exchange. And they released a number of playbooks, which are more or less implementation guides covering outpatients, which is the most mature, inpatients, and emergency, which are still work in progress, to document how this connectivity should be implemented. One of the benefits, for example, of using FHIR is the ability to uniquely identify patients, providers, and through their numbers assigned by Satu Sehat, as well as because of terminology is also a requirement for Satu Sehat, the ability to exchange information in a meaningful manner. So given the technological expertise in the country, using a modern API, modern REST-based APIs such as FHIR, will enable software developers to use technologies they're familiar with to quickly onboard to the system, to provide data and consume data from the national platform. And this should support quick onboarding and new and novel interoperability use cases, thus freeing up the data in the health system, which was one of the goals all along. This is what the consumer-facing application looks like. I do not speak Bahasa, but Bahasa speakers will understand. Again, it's mobile application for patients. Initial use cases were just COVID records. Now it includes a lot more functionality. That data is, again, collected, centralized, and available on the platform in the cloud, and it can be accessed, for example, through dashboards. And as more data is added to the platform, more data becomes available, providing insights into the healthcare delivery in the country. So putting all of these components together, this is an overall view of the ecosystem. So on one hand, we have the individual participants, the patients, which access the platform through their mobile applications. In the center is the platform, the Satu Sehat platform, which is in the cloud, FHIR-based. And in the middle, we have, as mandated by the government, all of the other participants in the health system in the country, hospitals, clinics, and so on and so forth, which are supposed to onboard to the platform, provide data as per the playbooks, and access data as well through the FHIR protocol and with the terminologies mandated by the government, again, in the implementation guides they released. And all of this data is aggregated, centralized, and available for use by the participants in the system. And I should say this is a work in progress. Not all of the APIs are available, and obviously the onboarding of participants is still going on for the hospitals and clinics. Indonesia is a very large country with numerous hospitals and health facilities. Taking a step back, what's a health information exchange? As per Wikipedia, it's the mobilization of healthcare information electronically across organizations within a region, community, or hospital system. The goal is to facilitate access to data, to provide safer, more timely, efficient, effective, and equitable patient-centered care, which should also benefit the public health authorities in analyzing the health of the population. So similarly, these are some of the goals that Satu Sehat has, basically to improve the transparency of the Indonesian health system and improve access to care. Now, InterSystems, as a health technology and health data company, has been active in this HIE space for quite some time, since the beginning, since the early 2000s, both in the US, starting with the Brooklyn HIE, and now in the US we have more than 113 million patient records in different regional HIEs with data source from more than 6,000 data sources, as well as around the world, in UK, UAE, China, and so on. So we have experience with the different HIE models and requirements. And HIEs have been around for a while, so the standards and the protocols behind them have evolved. And currently, FHIR has been a prominent protocol, and it's been mandated around the world, including in Indonesia, as the standard for data interoperability and data access. So I'll talk a little bit about what we delivered, as well as our approach. So our goal was to support Indonesian organizations, healthcare delivery organizations, whether hospitals or clinics, or whether they are our customers or not, to support them to onboard to Satu Sehat. So to support them to be able to connect to Satu Sehat to provide data and query data in FHIR. So that meant being able to extract data from their system, whatever form that data is available in, depending on their maturity level. If an EMR with APIs is available, or we can connect to the database, or only if text files are available, all of this should be possible to extract data, map it to the required terminology as per the government government requirements such as SNOMED, ICD, and I think it was mentioned before that this mapping has to be done. It's required for data to be meaningful. Transform it to the FHIR format, the FHIR data format, and then send it to the government API. Now, Satu Sehat is an API, which means data is submitted to it, but the submission may fail. The data is not valid, there's a problem of other kind, so it's important to be able to trace the transmission of the data and resend if that's required. So that's what we do with the routing and the validation. And not just this, but we also store the data in our IRIS platform, in the FHIR repository, which is part of the IRIS platform. One reason is for the ability to validate and resend the data, but there are some other additional benefits that I'll talk about in just a second. So in order to do this, to deliver this solution to the Indonesian market, we assembled a team of IRIS experts, as well as native Bahasa speakers, both from our company and from within the ecosystem at large. So we collaborated with the health IT community here, and we analyzed the playbooks released by the government, and we quickly iterated and developed a solution that supports onboarding to Satu Sehat, built on our IRIS for Health data platform. And again, it's a work in progress because Satu Sehat itself is a work in progress, but you can see our current status or our current solution available in the corner, and you can see a live connection to Satu Sehat. So I mentioned we store the data in IRIS, and that's important because we found out there are other potential use cases that you can find once you store curated and standardized data in a repository. IRIS is an API, has an API management layer. It's an application server, if you will. That means you can build mobile applications to use this data. You can connect to other participants in the ecosystem, such as insurance companies, if and when they will be interested in this. Analytics is a possibility. We have a component called the FHIR SQL Builder, which allows us to extract unstructured information from FHIR, present it in a tabular format that can be used with any kind of reporting tools. So a whole new world opens once data is available in a standardized format. So this, as I said, it's a work in progress. We are closely following the developments in the market, and we're updating it as the new requirements are issued by the government. One important concern and one common concern and one thing we hear a lot from customers is security. And indeed, security is a key factor for health data, specifically in the context of HIE, where data is shared from multiple sources. And this comes from the Office of the National Coordinator for Health Technology in the US. Core competency of HIE is to maintain a trusting and supporting relationship with the organizations that provide and consume data. And that is achieved by a combination of legal agreements, advocacy, and technology. So I think what I really wanted to show here is that security is not only, it's primarily actually not related to technology. There are other things which are part of the framework that need to be in place for security to be achieved throughout the system. So policies have to be there. The services which define and enable the policies, so identity assertion, credentialing management, audit trail, all of these have to be well defined and included in the playbooks and the implementation guides. And then based on these architectures, which are vendor neutral, technology neutral, it should be available. And only then technology becomes important, which has to support all of these components. In the case of Satu Sehat, as I mentioned, it's a work in progress. So policies and even architectures could possibly change. And we noticed this during our work that, for example, the developers of Satu Sehat kept adding more and more data validation. So queries or submissions that used to work before all of a sudden don't work because new guardrails are in place. Additional security was added. The patient opt-in, opt-out has changed. So this is important because, again, by using IRIS, we were able to quickly adapt to these requirements and meet them. And obviously, IRIS includes all of the global standards for authorization, authentication, role-based access, encryption for data at rest and in transit, full audit, as I mentioned, because all of the data is persisted in IRIS. So we meet all of these current requirements, and we are confident that we'll meet new requirements as they evolve, because IRIS is a rapid health data platform for rapid application development. So to kind of summarize all of this, some of the benefits and some of the benefits that IRIS as a platform and FHIR itself brings to customers, we were able to quickly develop and are still developing a platform that provides compliance with the Satu Sehat mandatory requirements. So this is already available. Not just this, but customers using a platform like this that actually stores data and cleans data and standardizes data in a local repository. So that provides organized clinical data in a universal language, such as FHIR, which can then be used for other use cases such as analytics, building applications, and future-proofing against other requests, such as I mentioned, possibly insurance organizations or others being interested in consuming this curated data. And finally, I think it's important to have such a standard data available because that enables data sharing, not just in the country, but in the region and possibly even globally, especially in such a geography where health data, genomics, and other data is not widely available globally. So that opens up a lot of areas for research and data use that we can only think about now. And for me personally, and for our team, it's been a very exciting project, not just because of the technology, but because of the impact and what we see that is possible. And we're hoping to continue our journey, both in Indonesia and hopefully in all of Southeast Asia at some point. With that, thank you.